This is the RheumNow podcast. Today is January 24, 2025, and I'm Jack Cush with RheumNow. I want to remind you, RheumNow.live is coming up in 2 weeks. You want to register as soon as possible so you're not going to be left out. You know, what happens when you turn on your radio station that, your go-to? What's your go-to? Is it The Blend? Is it the Tom Petty channel? Is it all Beatles all the time? And what happens when I turned on the 80s yesterday, because I thought the 80s were my year for music. And they played like 9 songs in a row that were like, how does that happen? Why don't they give me what I want all the time? I fear that today's podcast, maybe you might have tuned into the wrong channel, because, there's a lot of interesting stuff that happened this week. You're gonna have to judge for yourself. So Korean biologics registry called Kobio, good registry, they do good data. They looked at their patients with spondyloarthritis and looked at the frequency of infection and showed, not surprisingly, patients with ankylosing spondylitis, spondyloarthritis, have a higher risk of infection, especially serious infection. They studied over almost 2,100 AS patients, follow them for 7,100 patient years. That's either 7,000 patients followed 1 year or 1,000 patients followed 7 years. You figure it out. And the incidence of infection was 2.6 per 100. That was actually higher than their control population. The next most common, by the way, those were respiratory infections. So that would mainly be pneumonia, right? The most common, and goes way down, like 75% down, is herpes zoster at 0.6 per 100 or 6 per 1,000. Risk factors for infection were, as we talked about before, comorbidities, age, diabetes, heart disease, CKD, having peripheral arthritis as a risk factor. Maybe that's a risk factor for more severe spondylitis. Anyway, how are you going to rank this particular abstract? Get out your ranking cards. Let's rank on a scale of 0 to 10. We're going to drop the high and the low and take the average. I give this about a 6, right? So a French study looked at stable methotrexate patients and who were on methotrexate for many years, and they examined polyglutamate levels and its association with disease activity. It's a small study. Already the score is going to be low. It's only 34 patients, 25 of whom were in remission. And they showed that there was a good correlation between remission and the higher levels of PG3 polyglutamate levels. But this only applied to patients with a BMI that was normal or less than 25. This is yet another reason why I don't do methotrexate polyglutamate levels, because, I think you would do it if you weren't getting the most out of methotrexate and you wanted to get more and you had no other opportunities. We now know that from the study and others that obesity may get in the way of these ascertainments. What's your score? Yeah, that's a 4. Celiac disease in anything gets a 2 in my book. I don't mean to disrespect celiac disease, except it comes up a whole lot more than the disease actually exists. Do you agree? So this is a study of RA patients and association with celiac disease, and they looked at like a bazillion patients, 70,000. This is like claims data over 10-year period, something. 70,000 RA, almost 300,000 controls, follow-up 9 years, and they showed celiac disease had a higher prevalence in RA patients at a prevalence of 0.24%. That's 2 per 1,000 versus the controls, which was 1 per 1,000. And this was mainly seen in females. Yeah, this stays a 2 because it's 2 per 1,000. I mean, I do celiac testing. I'll do antibody testing, which is not totally reliable. And if the patient's concerned about it, I'll give them a handout on a gluten-free diet. And if they're having problems, I really suspect it, I co-manage with GI. But this is really not on my radar 98% of the time. Fault me for not putting it on my radar, but that's the way it goes. Another Korean population-based study showed that the incidence and prevalence of ankylosing spondylitis increased almost 3.5-fold between 2010 and 2023. So I already told you they got thousands of ankylosing spondylitis patients in that COBIO registry. This is not a COBIO registry study, by the way. This is a population-based study based on coding, right? So the incidence in 2010 was 27 per 100,000, went up to 82 per 100,000 in 2023. Is that a shocker? Well, it's a big jump, is it not? In a 10-year period or 13-year period, it goes up 3.5-fold. And what went up was the number of people that were diagnosed after the age of 50. It went from 20 to 33%. Females, 18 to 24%. Those with comorbidities, the use of TNF inhibitors went up, while DMARD, conventional DMARD, i.e. methotrexate sulfasalazine, went down. So is this just not greater awareness, better education? Do you really think that the frequency of the disease has had a 3-fold population increase? I don't think that's the de novo cause. So get out your scorecards. Again, this is maybe 3 or 4. But I like putting these kind of things up, if only to get you thinking, if only to argue, to only discuss with your colleagues. You should always be suspect of the next 2 studies because they are meta-analyses, systematic reviews. And I don't rank those very high, but sometimes when you can't get data, that's the best you got. So this systematic review claims data on 130 million people and 1 million with dementia found that the risk of dementia and Alzheimer's was reduced by the use of antimicrobials, vaccinations, and nonsteroidals. Well, that's why I put it up. Nonsteroidals. Hey, we rheumatologists, we're preventing dementia. But we rheumatologists are not using nonsteroidals as we once did during my fellowship in the 80s and 90s when that's pretty much all we had. Most of the current fellows are not using much in the way of nonsteroidals. I don't think that they're bad. I think you have to make sure that you don't use them in people at risk. But here's another side benefit to nonsteroidals, as there is a benefit to the reduction in colon cancer and polyps, right? And a whole bunch of other cancers associated with use of nonsteroidals, especially COX-2 inhibitors. So why antibiotics and vaccines? Well, those are people that are going to the doctor more. You could say the same thing about nonsteroidals. What was associated with an increased risk of dementia and Alzheimer's? Being on a diabetes drug, taking vitamins, and taking antipsychotics. I put this up there because of the nonsteroidals. I put this up there because of a lot of us have people in our lives that worry about Alzheimer's and dementia. And I think it's important to know this kind of data. A Still's disease study done by Ruscetti and colleagues in Italy, great group. They do a lot of good Still's research. They did a review of their registry and patients that had lung disease with Still's disease. And they affirmed that pleuritis was the most common of the manifestations. It was, I think, 75% of patients in pleuritis. Other large population studies with Still's say it's about 65%, 70%, where it's a presenting or feature once a diagnosis is made. Usually it's a presenting feature. And parenchymal disease, which could be pneumonitis, they had at 35%. And then other things were really, really rare, including pulmonary hypertension. What they commented on here was this association of lung disease in Still's, whether it's kids or adults, and bad lung disease, and that being associated with the use of IL-1 or IL-6 inhibitors or certain HLA haplotypes. Well, they didn't do any genetic studies here. They did not show any association between the lung disease of Still's disease with IL-1 or IL-6 inhibitor use. So because I'm an IL-6 and IL-1 and Still's disease maven, I'm going to give this an 11 on a scale of 0 to 10 because, you know, this is the kind of stuff that gets me going. A population-based study of almost 1,000 patients with gout and they were, as you might expect, in their 50s, 3/4 male, mostly white, that the burden of gout flares was 6.6 flares per year. Oh my goodness. But the real point of this paper was that, and this was data taken from patients, right? They were surveying the patients themselves. But 72% of the patients said they did not report their flares to the doctor, or that their flares were not being pre-treated or prevented with some medicine to prevent flares. Wow, this is yet another area that we should be tackling in gout management. The ones who are less likely to report their flares to their doctors or healthcare providers were they were younger, less education, they had fewer comorbidities. It's kind of as you might expect, young and stupid. Unfortunately, when you're young and you have these diseases, you make all kinds of wrong choices, and that you have to learn the hard way, or by going to a good rheumatologist who can educate you and make you smarter than stupid. Anyway, a post hoc analysis of gout and pegloticase was published by Orr and Traum this past week, or this past month. Using the data from the 4 registration trials with pegloticase, they showed that rates of major adverse cardiovascular events and thromboembolic events, DVTs, VTEs, etc., these were actually quite rare. They were less than 1.5%, or only 3 events per 100 patient years. And this was similar to other gout patients, right? So these are patients in the pegloticase trial, presumably really severe gouts, compared to the general gout population. Those MACE events and VTEs were not increased, and I think this is important to know because many of us are not using pegloticase. Pegloticase is a major advance for major league, really severe gout. To not use it is a shame. This data and other data that's been put out suggests that it is safe and you should be considering it. Medicare came out with a new announcement. As you remember, last year under the Biden administration, they announced that they were going to negotiate prices of drugs, especially expensive drugs, with Medicare. Medicare was going to negotiate these with the manufacturers, and they listed 10 drugs in 2024 that they were going to negotiate going forward, and this included ustekinumab and etanercept as expensive drugs that they needed to negotiate. They came out with another 15 drugs, and yes, our drugs are on the list. This includes nintedanib, also called OVEF for pulmonary hypertension, and IPF, and apremilast or Otezla also are going to be negotiated, as are the GLP-1 drugs going forward, because they're very much in vogue and it's kind of a hot button issue. I think this is a great advance in how we're going to manage the cost of drugs. Another VA study was published this week talking about the risk of multiple myeloma in RA patients taking either biologics or targeted synthetics, and amongst 27,000 RA patients, 30% of whom were taking either one of these advanced therapies, including biologics. There are only 77 cases of myeloma, and biologics and targeted synthetics were not associated with a risk of myeloma. I'm sure you weren't even aware that it was a possibility. I'm sure you didn't think that this was possible. And my telling you it's not possible is like, why are you wasting my time? Yeah, you can give this a 1 if you want, but I like bothering you with Picayune data. And who knows, maybe this discussion is going to come up in Peoria in the next week on rounds. Well, I heard last week that there is no association with myeloma and biologics. It's based on a VA study of 27,000 RA patients. How could you, my mentor, be arguing with me about this? These are the facts. Stay up to date, dude. That's why I report this stuff. Inflammatory arthritis and depression, we've talked about it before. And there's a report this week from Canada looking at almost 7,000 patients with inflammatory arthritis, showing that 7,000 patients with inflammatory arthritis and depression. And then there were 3,000 patients with inflammatory arthritis and anxiety. And both of these populations were vastly undertreated for any kind of treatment for their depression or anxiety, or specific treatment for their depression and anxiety. Again, I strongly urge you to ask the question, Do you have depression? Is depression an issue? Do a PHQ-9 survey. Use my RheumNow survey or Ted Pincus's MD Hackett asks about those things. We're going to end with getting to remission without biologics. This is an article that I saw in Helio, by the way, that the same day it came out, and I put it up on RheumNow at the same time. It's a report out of Lancet Rheumatology, and it's a cohort study of 1,000 patients with early rheumatoid arthritis. And the investigators who run these early rheumatoid arthritis clinic, the EAC out of Leeds, run by Paul Emery, and the T-REACH study out of Rotterdam, that's another early arthritis study. These investigators must have had a conversation over a pint about, we don't see remission in people that go on biologics. Or they saw the converse, which is what they say in this paper, is that if you didn't need biologics with RA, you had a much better chance of getting to remission. So 600 patients with early arthritis out of Leeds, 14% were on biologic, 86% were not. The people on a biologic, none were in remission. 37% who were not on a biologic, right, actually achieved remission. Gigantic difference here. The same was seen with and that's a 5-year outcome study. A 3-year outcome study from T-REACH in Rotterdam, 425 patients. They had 36% who had been on a biologic, and 0% of them were in remission at 3 years. And of the ones who did not receive a biologic, 15% went on to achieve remission. So this is either a brilliant study or a duh. What are you thinking? Of course, if you don't need biologics, well, you're not that bad, and you're probably got a better chance of getting to remission. But I also like the idea that this designation of whether you receive the biologic or not is pretty much up to you. You make that decision, right? It doesn't require expensive tests or doing 10-finger calculations to get to a GAS score, CDI score, SDI, whatever you like to do, Rapid 3. I think that you can tell when someone's has good disease, you should be expecting remission or striving for remission. Maybe if they have difficult disease and they need to be on a biologic or combination of drugs, it's going to be harder. And maybe you'll never get to remission, but you can certainly get to low disease activity state. I like that one. I'm going to give that one an 8. You might give it a 6. Bring your scorecard next week. We can see if we can do better. RheumNow.live, February 8th and 9th. I want to talk about the keynote speaker, Dr. Charity Dean. I learned about Dr. Charity Dean by watching a masterclass on writing by the famed author Michael Lewis. Michael Lewis wrote many famous books. I think he's written 20 books, but including Liar's Poker was his first book. But The Big Short became a movie. The Blind Side with Sandra Bullock became a movie. My favorite movie, Moneyball, became a movie. He writes great stuff. He wrote a book during COVID called Premonition. He tells a story about Dr. Charity Dean, who, after her residency, became like the county health commissioner for Santa Barbara County. And one of the first things that she encountered was a report of TB. Santa Barbara is a very rich county, but also a very poor county with a lot of migrant workers. So TB is a problem over there. And in seeing this report, she asked the question, does this person have pulmonary TB? Because if it does, she's got a problem and has to look at spread. They didn't know. So it was a case of TB meningitis. So she said, we got to find out. Let's exhume the body. So the story that he tells is she calls the medical examiner, who's like an old crusty guy with a cigar like Quincy, and says, lady, I'm not exhuming the body to find out if it's got TB. You're out of your mind. And he hangs up. She reminds him that she's his superior. He still hangs up. She calls the chief of police. Chief of police says, I'm not going to tell the ME what to do. I shoot pool with that guy. Lady, you're out of your mind. Well, she calls the governor. And the governor tells the chief of police to tell the other guy, exhume the body and get it done. That's what happens. They exhume the body. But they're reluctant. They don't want to do it. They don't like this young whippersnapper woman who's telling them what to do and who does she think she is. So on the day that they're going to do the autopsy, it's around Christmas. She's in her car. She's got a sweater on, a holiday sweater and jeans and flats on, and she's at a party, and she's going to go by and check out the autopsy. She pulls up to this little brick cement building, one story, and there are 5 men outside in hazmat suits. And on the dirt ground, there's a picnic table, and on the picnic table is a body bag. And the men in hazmat suits are doing nothing. And so she goes over and says, what's going on? When's the autopsy? And we're not doing it, says the ME. We're just not going to do it. She points to the chief of police. Tell him to do it. I can't do that. She's mad. She's really mad. She says, fine, I'll do it. Give me the saw. I didn't bring the saw to crack the chest. But here are some garden snips from Home Depot. You can get the lung that way. So she goes over the body. She struggles a little bit. She snips a few ribs. And the men in hazmat suits, they're gaping. Their mouths are wide open, hitting the floor. They can't believe this young whippersnapper blonde woman is doing this. And she reaches in the lung, in the chest cavity. She pulls out a soggy mess, a deflated lung. She says, give me a specimen bag. They don't have one. She reaches over and grabs the orange Home Depot bucket, throws it in there, walks away, puts the bucket in her trunk, and drives away. As soon as I heard that story from Michael Lewis, I went and read the book on premonition. It's a pretty good book. Tells you a lot of things you didn't know about COVID, but this is an interesting person who's got a lot to say about doing it right in medicine, and that's why she's our keynote speaker on Saturday at 4 p.m., February 8th. Be there at Room Now. I'm going to be.